Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 9F. And this is Cytopathology. We are streaming live from Kuwait City via Kolkata. And today's topic is very interesting. It is FNAC in liver masses, approach to diagnosis. And to talk on that, we have Dr. MRINMAY, who's an MD from PGIMER, Chandigarh, consultant cytopathologist from Mubarak Al-Kabeer Hospital, Kuwait. Dr. MRINMAY has been working as a consultant in cytopathology for more than 2 decades and has been teaching graduates as well as postgraduates in renal pathology and laboratory technology for about 2 decades now, and has published many research papers in peer-reviewed national and international journals. His areas of interest is soft tissue, thyroid, and gastrointestinal tract pathology. So with much ado, I would just request Dr. MALLIK, sir, please share your screen and let us start.
Right. Nadeem, just guide me through this once again, please, because
I will surely. Just press present now on the right side of your screen.
The entire screen?
Entire screen.
Yeah.
Press on the center of the screen and press share.
Press the center of the screen and
The
press
share button
share.
will pop up.
Yep.
Yeah, that's right. We can see your screen.
Right.
Just share your PowerPoint.
So
Okay, just press that hide thing so that it just disappears.
it goes.
Right. So please start.
So am I audible?
Yeah, perfectly clear.
No reverberations, I guess.
No.
So good evening to you all and a very warm welcome. So today I'll be talking about FNAs in liver masses and some of the diagnostic approaches that we take. But at the very beginning, I would like to start with a kind of a humbling note rather, because at least in our practice, there has been a precipitous decline in requests for FNAs in liver masses over the recent last few years. It is driven primarily by some of the management guidelines which rely heavily on imaging techniques, and many of the times when they need to get a diagnosis, they do a core biopsy. At the same time, I'm sure that there are many practices, and I was just speaking to Nadeem a little while ago, where you still get a lot of FNAs, and some of them can be extremely challenging, as we are all aware of. And through this webinar, I would like to highlight some of these challenges and what are the things that we can do to overcome them and an overall approach to the diagnosis. So the patterns which I shall pursue, and this choice of word is for you, Nadeem, is that I'm going to try and look at the FNA picture in hepatic masses as a pattern of 6 different types. And most of the lecture or the webinar is going to be on the first 3. This is going to occupy most of our time. Well-differentiated HCCs and their look-alike, moderately differentiated HCCs and poorly differentiated HCCs. And then I'm going to follow it up with undifferentiated and blue round cell tumors, some spindle cell rich regions, and aspirates which are rich in cells of lymphoreticular origin. Now, I'm leaving out predominantly cystic lesions, inflammations and infectious etiologies in general, which can lead to masses due to time constraints, and I'm also going to leave out certain things like technical aspects, complications, contraindications, and controversies related to liver FNAs, because they are going to take a lot of time. I don't want to go into those things today. So, to start, I have decided to take the first 3 of these patterns, and there is a very nice cue which I got from the WHO grading of HCCs. And the 3-tier WHO grading of HCCs are as follows. So they are called well-differentiated, and this is a representative picture. It's a small picture, but you're going to see bigger ones later on. Moderately differentiated and poorly differentiated HCCs. So all these 3 are HCCs. So a well-differentiated HCC by definition is a tumor where the tumor cells resemble mature hepatocytes and they show minimal ATP. A moderately differentiated HCC is one where they would still have a very close resemblance to hepatocytes, that they look like hepatocytes to a great extent, and they show a moderate degree of nuclear ATP. So you are able to say that, well, I think this is malignant. This is something which is going to be malignant, but not as much as in case of poorly differentiated HCCs, where the cells almost lose all resemblance to hepatocytes, shows considerable nuclear ATP at times, and these cells are pretty easy to call malignant. In fact, I feel that both of these two types are quite easy to be designated as neoplastic. So, let's look at the first one. Well-differentiated HCCs and the lookalike. And it's kind of a short, I won't say a test, but just for fun. I'm going to show you like 5 pictures. And they are 5 different lesions. One of them is an HCC, and the other are the lookalikes. So what are these 5 different lesions? Let me just unwrap it. So the first one are actually benign hepatocytes, non-neoplastic. This has come from the adjacent liver tissue of a lesion which was targeted by FNA. This is a representative slide rather of a regenerative nodule. This is the hepatocellular adenoma. This one is a focal nodular hyperplasia, whereas this one is a well-differentiated hepatocellular carcinoma. Now, if you look at them once again, you are going to see that it is very difficult to differentiate between these 5 conditions confidently just by looking at these pictures. So, these are the lookalikes: benign liver component, hepatocellular adenoma, focal nodular hyperplasia, regenerative nodules, and hepatocellular carcinoma well differentiated. Now, first of all, let's look at the benign liver cell components, which come most often from an area adjacent to the FNA target. And when that is sampled, we see these benign hepatocytes. They can come out because they are adjacent to a mass lesion. They might show some kind of reactive regenerative changes. Like here you have got a hepatocyte with 3 nuclei, and there is a bit of a discohesion. You might see some changes in the cytoplasm, and you can actually see intranuclear inclusions, and that does not mean that this is the HCC. So you can see intranuclear inclusion even when it is not an HCC. Right, just a quick look at how the appearance of lipofuscin on PAP as well as on MGG smears. And this is lipofuscin as opposed to bile, which has got a much more waxy kind of a coarser appearance, a little bit greenish in color as far as I can say, as compared to lipofuscin, which is actually much finer and has got a kind of a yellowish brown appearance, but sometimes it can be very difficult. So let's start with the first one in the group, hepatocellular adenomas. So females are affected more often than males. They actually can be multiple. They have a strong association with oral contraceptive pills. MRI is pretty good in telling things as hepatocellular adenomas because of features that we see on MRI. Hemorrhages are quite common, and these tumors are classified into the following groups. And these are ones which are, let's start at the bottom here for this, in this case, not otherwise specified type, that is the so-called garden variety of hepatocellular adenoma. And then you have got types which are described as ones with a mutation, one with HNF1 alpha mutation, one with beta-catenin mutations, then and there is an inflammatory type. It is important to remember these because they have certain morphological changes associated with it, as we are going to see very soon. So, as far as the cytomorphology of hepatocellular carcinoma is concerned, you are going to see, like all other members of this group of lesions that we are discussing, of this pattern of lesions rather, a uniform population of bland hepatocytes. They might show a very prominent fatty change in some cases. This is a very important point. Bile duct epithelium is almost always absent. Now, this point helps to differentiate it from focal nodular hyperplasia. I'm going to talk about it later. You might find necrosis and sometimes might even find granulomas. Some of the hepatocellular carcinomas, especially those with HNF1 alpha mutation, show steatosis. The ones with beta-catenin mutations can be very tricky because they can show pseudoacinar arrangement as resembling HCC. They can show significant amount of ATPR2, raising concern. And also we have to remember that some hepatocellular carcinomas can get converted to malignancy. There could be malignancy which can arise, HCCs which can arise in hepatocellular adenomas. Then there is an inflammatory variant which shows a lot of inflammatory infiltrate, and it has a poor circumscription, a point which is not important from the cytologist point of view, but from the angle of histopathology, the poor circumscription is. Right. The IHCs and special stains are pretty interesting because here the reticulin is intact. It is going to show HepAR1 and arginase positivity, so I have not mentioned arginase here. Glypican is negative. However, there is something else associated with it anyway. CD34 shows a negative, is usually negative, but it can show focal incomplete staining, and this is very vital for us to remember. The beta-catenin mutated type is going to show a nuclear beta-catenin, which actually may be focal. One should remember that. And the inflammatory type is positive for SAA and glutamine synthetase. Right. So these are some of the pictures of hepatocellular adenoma. As you can see over here, that these are very, very bland looking hepatocytic cells, little bit of a discohesion present in the form of sheets and clusters, no bile ductular cells. This is a hepatocellular adenoma which was reported to our department, although we didn't have mutation studies, but this one showed an abundant amount of fat, which as we know is often associated with HNF1 alpha mutation. Next, focal nodular hyperplasia. Once again, there is a female preponderance, they can be multiple, but very classically on imaging, there is a central scar, which is a very, very useful pointer to note. On cytomorphology, once again, it is indistinguishable from normal and reactive liver tissue. And biliary epithelium is present, and this is a very key point because biliary epithelium is absent in hepatocellular adenomas, and biliary epithelium are usually absent in hepatocellular carcinomas. So this is a very important point to remember. So of these three, this is the one which, if biliary epithelium is present, it helps you with your differential diagnosis. On immunohistochemistry, because these are hepatocytic, these cells are going to be positive for HepAR1 and arginase, and therefore, if you're trying to differentiate between these lesions, these two antibodies are actually of no use. However, glutamine synthetase can show a patchy map-like pattern, at least as far as the reports on histopathology go. I've never really seen one of them on cell block to have tested, so I'll not be able to tell you, but it does have a patchy map-like pattern, which is very well recognized. CD34 is very important because in hepatocellular carcinoma, there is a capillarization of sinusoids, as you're going to see, whereas in the two benign counterparts, the two benign lesions in this group, that is FNH, which is focal nodular hyperplasia, and hepatocellular adenoma, you do not see the capillarization of sinusoids. But at the same time, you have to remember that in both these lesions, you may pick up some marginal focal CD34 related capillarization of sinusoids. So that is something we should remember. So on cytomorphology, the focal nodular hyperplasia just looks like benign hepatocytes. In certain areas which are not seen over here, you're going to see, you might pick up bile duct epithelium, which is of great help. Now, let's go to the last one in this particular group, hepatocellular carcinomas in general. We are talking about the well-differentiated variety, but this is just a general kind of a slide. the antecedent predisposing factors leading up to cirrhosis and other antecedent factors which are in the etiological list of hepatocellular carcinoma is very important to know and remember. There are very typical imaging findings which make the imaging reports pretty reliable, and hepatocellular carcinomas may be multiple, so if one tries to use it to differentiate from metastatic tumor, one needs to keep that in mind. You can have multiple hepatocellular carcinomas. So in the well-differentiated hepatocellular carcinomas, you can have sheets, clusters, and isolated cells. You can find an acinar formations and trabecular arrangement. If you find these, they are very helpful. The trabeculae may show endothelial skirts, that is a wrapping of the trabeculae by endothelial cells. There might be runs of capillaries inside. The cells, of course, resemble hepatocytes very closely. They may have a granular vacuolated cytoplasm. The degree of pleomorphism can be very variable. There may be nucleolar prominence, and there can be some degree of chromatin abnormality, but all these features are pretty low. And you can have variable presence of bile, lipids, and even some cytoplasmic inclusions. So this is from a well-differentiated hepatocellular carcinoma. See the very close resemblance to hepatocytes, right? There are intranuclear inclusions over here, and there is a bit of bile outside the cells. This is another pic showing a hepatocellular carcinoma, right? So a couple of other shots of hepatocellular carcinoma. See the very, very close resemblance to benign hepatocytes. This is the MGG stain. So, what should be your approach towards the differential diagnosis in this lesion? You should try and grab the hints from epidemiology, from the presence or absence of cirrhosis. The use of alpha-fetoprotein, well, it is about 60% sensitive, around 90% specific in HCC. So there are a lot of HCCs which do not show rise in alpha-fetoprotein levels. But if they show a rise, they're pretty helpful, because most of the times in hepatocellular carcinomas and focal nodular hyperplasias, alpha-fetoprotein levels are within the reference range. Imaging are extremely accurate in identification and characterizations of these focal lesions. So, what about the role of special stains and immunohistochemistry? I would say that these are possibly the most useful ones, right? Reticulin is very useful. You can do the reticulin on the cell blocks, and you find it very useful. In both the benign condition, the typical reticulin pattern of wrapping around the individual hepatocytes and the sinusoids is maintained, whereas in hepatocellular carcinoma, this pattern is lost. They seem to go around the groups of cells. The capillarization of sinusoids, I'm sorry, I've missed out mentioning the antibody, that is CD34, is diffuse in case of hepatocellular carcinoma, whereas in hepatic adenomas and focal nodular hyperplasia, they are absent, or if present, they are focal. The last three, glutamine synthetase, heat shock protein HSP70, and glypican, are extremely useful. Why? Because as you can see that for both the benign conditions, these three are almost always negative, except that focal nodular hyperplasia can show a patchy glutamine synthetase positivity. Hepatocellular carcinomas can be positive or negative. HSP70 is most often positive, glypican almost like a 50-50 or 60-40. Glutamine synthetase also can be positive in a number of cases. So if you have positivity in any one of these markers and you do not have this patchy map pattern, it actually helps in clinching the diagnosis in favor of hepatocellular carcinomas. The next most important thing is that it is very unusual to find negativity for all these three markers. So if you use a combination of these markers, you are going to pick up positive in at least some of them. So that is extremely important to remember. So this would be the most important immunostains. There is no use of doing things like HepPAR or arginase in these cases, because all the others, that is hepatic adenoma and focal nodular hyperplasia, is really positive. Now, I find routine cell blocks to be extremely useful. So this is a hepatocellular carcinoma on cell block. So here you can see the tumor and you can see the architectural change where the cells are arranged in the form of acini, maybe a few trabecular here and there, not very clear, but this is a non-lesional liver tissue right over here. This one is a hepatocellular adenoma and you can see the one or two single cell kind of cords over here, and this is a benign condition, the hepatocellular adenoma over here. So cell blocks sometimes can be of great help in this regard. This is the use of reticulin. As you can see over here, in HCC the whole reticulin pattern is disrupted. This is where the reticulin pattern is maintained in hepatocellular adenomas. As you can see, the reticulin is going around the hepatocytes over here, along the sinusoids here. Very thin strands of reticulin going around the big trabeculae of cells and some nests of cells here and there. So basically there is a loss of reticulin over here, a disruption of reticulin rather from the usual pattern. CD34 in hepatocellular carcinoma, there is a capillarization of sinusoids, as you can see here. CD34, normal liver cells do not show capillarization of sinusoids shown by CD34. I did the CD34 on hepatocellular adenoma and it just came out blank. The next group is going to be the one related to moderately differentiated HCCs and their lookalikes. So once again, we are going to start with a very similar exercise. So please take a look, pause a moment to look at these photographs. This is HCC. These are some of the lookalikes. Right? They look very, very same. It's very difficult to tell one from the other. There are a few hints, like you might find some very fine vacuoles over here. There is something shown by an arrow. There is a kind of a vacuole inside the cell. Otherwise, it's pretty difficult. So let's see what they are. This one is a moderately differentiated hepatocellular carcinoma, which still has a resemblance to hepatocytes, so many of the others don't. This is a variant of hepatocellular carcinoma called Fibrolamellar HCC. This one actually is an adenocarcinoma, which looks like liver cells, so it's called a hepatoid adenocarcinoma. We are going to talk about that. This is a METS from a renal cell cancer. This is a METS from an adrenocortical cancer. This one, well, it's a mesenchymal lesion. This is an epithelioid hemangioendothelioma, which can be very, very difficult if you do not keep it at the back of your mind to differentiate from a hepatocytic tumor. So, we have got 6 more. So, we have got 6 in the previous slide, 6 more. So, I've got a list of around 6. So, let's see. So, there is no hepatocellular carcinoma over here. They couldn't fit in the hepatocellular carcinoma in the middle. So these are the ones. Let's see what these are now. So this is actually a METS from an adenocarcinoma of the lung, which sometimes can look very, very, I hope I've got a good representative picture. I wish I could get a better one. This is an epithelioid angiosarcoma. That of course comes everywhere. As they say that on every list of differential diagnosis, there is a shadow of a melanoma. So that's a melanoma. It's a huge intranuclear inclusion. This one is an angiomyolipoma, which may show epithelioid areas, and some of these can look just like hepatocytic tumors. This is a hepatoblastoma, of course, occurring in children, the fetal pattern can show these kind of polygonal cells. You'll see some more pictures of that later on. This is actually a carcinoid with a kind of oncocytoid appearance, which may look like, sometimes may resemble a moderately differentiated hepatocellular carcinoma when they have an abundant amount of granular eosinophilic cytoplasm. So this list is pretty long. I think I missed out something from somewhere, but there are actually 12 of them, if I remember. So hepatocellular carcinomas, fibrolamellar HCCs, hepatoid adenocarcinoma, METS from RCC, adrenocortical, lung cancers, angiosarcomas, epithelioid hemangioendothelioma. Something is missing somewhere, but I think I've covered most of them. So let's start looking at the picture. So this is the hepatocellular carcinoma, moderately differentiated. As you can see, there is a pretty good resemblance to hepatocytes, but from the degree of nuclear atypia, both in this side, on the PAP, as well as on the KIM side. You can make out that these are clearly neoplastic and most likely malignant cells. The nuclei are enlarged, with some degree of chromatin abnormality, quite a significant degree of anisonucleosis, some pretty almost moderately pleomorphic cells. So when you look at these, you know that these are malignant. Now, so here too, another picture, cells breaking up from the periphery. Just maybe one or two cells which may look like endothelial cells, but as I've said before, that if the endothelial cells are present, they're helpful, but quite often they are not, so you may not be able to use them. So these are, this is again another HCC moderately differentiated. These can be very useful. These are the swarms of bare nuclei. When they are present, they are very useful. Okay, so you have to keep that in mind, but they are not always present. So this is another good look at those, swarms of bare nuclei, and you can see an intranuclear inclusion here. So when these are present, see one more over here, when these are present, it is extremely useful in helping you with the diagnosis of HCC. So this is the key statement which I've already mentioned. Next, we are going to talk about fibrolamellar HCC. So they of course look like liver cells, but they are like chunkier and juicier kind of hepatocytes. They're big cells. Okay, they're very, very sharp cytoplasmic outlines and big nuclei, very prominent nucleoli, abundant amount of cytoplasm, and there is a lot of cells which are present in a kind of a disc-cohesive pattern. So when you see these features, it should kind of ring a bell. And this is one article which was published from PGI Chandigarh. I'm so glad to put this up because three of my teachers from whom I've learned so much, Dr. Radhika, Dr. Pranab De, and Dr. Arvind Rajvanshi are co-authors in this article. And these are some of the representative slides where you can see the similar kind of humongous cells, very sharp outlines, large nuclei, prominent nucleoli. And when you do a cell block, this is what you see. And then sometimes you are going to see kind of stromal fragments which are associated with them. So when you see these features, they are helpful. So these are some of the features that I just spoke about. Loosely cohesive clusters, many isolated cells, abundant cytoplasm, very commonly bi or multinucleated. They can show huge nucleoli. There can be nuclear pseudo-inclusions. There could be pale bodies in the cytoplasm. Now, IHC is very interesting. They're positive for HepCAR, and there is no surprise about that. But unlike most HCCs, as I said, unlike most HCCs, they are positive for CK7, CK19, CD68 can stain the usual HCCs, but they show only a canalicular pattern, whereas in fibrolamellar HCCs, they show a canalicular as well as a cytoplasmic pattern. Another thing that one might do if you have the antibody is do a fibrinogen, and they stain the pale bodies positive. So what are the important points related to the differentiation between HCCs and fibrolamellar HCCs? So cytomorphologically, they're bigger cells with more abundant cytoplasm, more singly scattered cells. You can use CK7 and CD68. However, please remember that almost 30% of HCCs can be CK7 positive. Next, hepatoid adenocarcinomas. Now, I would have been happy to say that this is, when you see a hepatoid adenocarcinoma, it is only, hepatoid adenocarcinomas only occur, in a situation of metastasis, which is actually not true. Because hepatoid adenocarcinoma can be metastatic, but there could be cholangiocarcinomas and tumors occurring in the biliary tree, which can also have a hepatoid look. We are going to see that. So these are hepatoid adenocarcinoma. Just look at these. If somebody shows me this particular picture, these cells, I would not be able to confidently rule out the possibility of a moderately differentiated hepatocellular carcinoma. They look so much like hepatocytes, right? And this is actually one of our cases, which we reported recently. Now, in this area, they show a more eosinophilic cytoplasm. They have a greater resemblance to hepatocytes. Here you see kind of a vacuole inside the cytoplasm, so the resemblance is very striking, which could be a nightmare as far as the differential diagnosis is concerned. Now, hepatoid carcinomas, most often, they are carcinomas with a hepatoid look. That means they look like hepatocytes, but not only do they look like hepatocytes, there are about other phenotypic features which are like HCCs, which makes them extremely challenging. Now, they usually occur, or the most common site of the primary would be the stomach, lung, followed by the lung. They can occur in the ovaries, the pancreas, but there is a primary hepatoid adenocarcinoma of the extraepitheliary tree, which is known now. They show high alpha-fetoprotein levels. So that is one point which is not going to help you to differentiate from a hepatocellular carcinoma. The neoplastic cells are arranged in variable-sized aggregate with moderate to abundant amount of cytoplasm, just like a moderate differential HCC. And look at this, they may even contain bile. And hepatoid carcinomas in the lung has also been shown to contain bile. Now, what about immunohistochemistry? They are usually positive for CK7. The most HCCs are CK7 negative, which should help. But then we know that there are certain HCCs which are CK7 positive. They're positive for alpha-fetoprotein. The CEA is going to show a diffuse cytoplasmic pattern. I really do not know whether on polyclonal CA they show up canalicular pattern. I do not know the answer to that. I couldn't really find a proper answer to that. The positive for CK18 and CK19. HepAR can be strongly positive, at least focally. So this is another point as a result of which it is similar to the hepatocellular carcinomas. And look at this one. Even CD34 does not help because it may show a sinusoidal pattern. The extrahepatic biliary tree hepatoid adenocarcinomas are a bit tricky because there are different kinds of areas which they can have. They can have areas which are poorly differentiated areas, and there are certain areas which look just clear adenocarcinomas. Alpha-fetoprotein will be positive in both of them. The CK7 will be positive in the adenocarcinomas areas but will be negative in the poorly differentiated areas. And most importantly, glypican, it can be positive in poorly differentiated areas. You know, glypican is a marker of hepatocytic differentiation, but they can be positive in hepatoid adenocarcinomas. So, the key points are that the diagnosis and the differentiation of hepatoid adenocarcinomas versus HCC can be extremely challenging using both routine stain as well as immunohistochemistry, and a close correlation with clinical and imaging finding is absolutely necessary. Next, I'm going to talk about the three tricky METs as far as moderately differentiated HCCs are concerned. So here we go. This is HCC moderately differentiated. This is a renal cell cancer, METs from a renal cell cancer. This is an adrenocortical METs, and this is a pulmonary adenocarcinoma METs, right? And you see the look, I mean, in a kind of, doing a routine reporting, I mean, this could be a real challenge. So what can, of course, help you? The most important thing is that if you have a prior knowledge of what this patient has, right, that is going to be a great help. But as we know that more often than not, a good clinical history or a proper clinical history or an accurate clinical history is missing on the form. So it can be very difficult. So what can you do? You have to, of course, do the clinical and imaging correlations. As far as immunohistochemistry is concerned, you have to use a judicious use of antibodies, right? So if it is positive for HepAR, arginase, and polyclonal CA, this usually indicates a hepatocellular carcinoma. Okay, so one needs to, but there are a few pitfalls. I shall talk about that. Now, if you're trying to use CK7, as I always say, CK7, as I mentioned, can be positive in some HCCs. So do not, be careful if you're just using CK7. PAX8 is very useful in renal cell carcinomas, especially the classic, usual clear cell variant of renal cell carcinoma. backside is going to be very useful because these are CK7 negative, which is anyway not going to help. CD10 is of course not going to help in these circumstances because HCCs are CD10 positive. In pulmonary adenocarcinomas, if they're TTF1 and napsin positive, it is very helpful. But remember that HCCs can show positivity for TTF1 but in a cytoplasmic manner, and about 7% of pulmonary adenocarcinomas are HepAR positive, even if they are not the hepatoid adenocarcinoma type. With adrenocortical carcinomas, these tumors are the important immunos which you can do if you suspect an adrenocortical carcinoma to establish an adrenocortical carcinoma is melanomat, inhibin, which are usually positive. There is a very simple immunostain which most of the labs would have, that is, if you're use immunos, EMA. EMAs are negative in adrenocortical carcinoma, positive in all the others. But there are reports of HepAR positive adrenocortical carcinoma cases. So the key is to try and use a panel of antibodies if possible and not to base the diagnosis on one or two antibodies. And if doing so, always keep in mind the pitfalls and the caveats and keep the other possibilities too. So because a single one or two immunos is just not like a clean sheet to tell you, okay, this is this lesion. So it is always a panel, if possible, use a panel. Next. This is always a very, very tricky lesion. I think this is one of the lesions which more often than reporting one might encounter when you attend scientific meetings or interesting case seminars, because people like to give this, because this is very tricky. You know, it just looks like a hepatocellular carcinoma or a hepatocytic lesion, but it is not. So this is an epithelioid hemangioendothelioma. If there is a one mesenchymal lesion, which looks very, very which closely resembles a hepatocellular carcinoma, this would be one that I would always keep at the back of my mind. When things don't make sense, ask yourself, am I dealing with the epithelioid hemangioendothelioma? Because they can be asymptomatic. They can lead to some kind of, sorry about that, kind of discomfort. They can present with hemoperitoneum. MRI in some cases might give you some hints that you might be dealing with the epithelioid hemangioendothelioma of the liver. You can have a mixture of singly scattered and loose aggregates of cells. Cells are mostly oval to polygonal, and that's exactly where the problem, that's why they look like hepatocytes. They could show variable degrees of pleomorphism. That again is an issue. There could be stromal fragments, which can be there, but in HCCs too you can have stromal fragment. The things to look out for, and they're not always present. They're present possibly in 30 to 40% of the cases, according to some of the reports, are the presence of intracytoplasmic lumina, okay, which may or may not show RBCs. So what are you going to do? So these are the stains that you might like to do. CD31 and CD34. So CD31 is not positive in HCC. CD34, you have heard, could be positive as a result of the capillarization of sinusoids. Okay, so this is helpful. ERG is helpful. These tumors are quite notorious because these are one of those mesenchymal tumors which can be cytokeratin positive. So cytokeratins are not going to help, right? But they are negative for EMA, which is pretty helpful, and they are negative for HepAR1. So you can use a combination of these markers just in case you have a doubt. Right. Next, Angiosarcoma with epithelioid features. So this is a representative image from an article which came up in Cancer Cytopathology around 21 years ago. So it's a primary epithelioid angiosarcomas of the liver are extremely rare. Okay? They could be METs. They have scanty to moderate amount of cytoplasm, oval to polygonal stem. That's exactly why they look like hepatocytes. They're kind of a fraying at the margins. And pleomorphism, well, that is very interesting. The pleomorphism is mild to moderate. It's not that always you're going to see very severe pleomorphism. Nuclear prominence is very common. So epithelioid angiosarcomas are one of those tumors you have to remember, where if you see them, the nucleoli literally stare at you. Okay, so remember those. CD31 is positive. CD34 can be positive or negative. Again, one of the tumors, just like the previous ones, which can be CK positive. And these tumors rarely can even be EMA positive. So you have to really keep your guards up. Next, angiomyolipoma. Thanks to Dr. Pranab De, Professor Pranab De from PGI Chandigarh. It's a very rare primary liver tumor. Remember, it can show epithelioid cells, spindle cells with smooth muscle differentiation, fat and blood vessels. So if all these things are present, it's pretty helpful. But what if the lesion, what if the needle goes and hits or samples one area, but just it has epithelioid cells? It can be tricky because the epithelioid cells are oval to polygonal, with a kind of ample cytoplasm, can show anisonucleosis, can show prominent nucleoli, right? So these are again one of those tumors which are HMB45 and melanA positive, but they're negative for cytokeratin, and also they're negative for inhibin. Just in case you're thinking in terms of you're seeing those large cells, you're thinking in terms of a metastatic adrenocortical CA. Right, and this of course, as I said, is everywhere, and liver is the second most common site of mets in melanomas after lymph nodes. The cytomorphology is extremely variable. Epithelioid cells are one of the types which are known to occur in melanomas. If you can identify melanin pigment, it can help. Of course, the immune panel comprises of HMB45 and melanA. You have it, and it's negative, which is very useful. It's usually negative for cytokeratin, negative for CD34. I wanted to add this one to this list. Although typically neuroendocrine tumors have a very, very classic appearance, and you should be able to most of the time get the hint from the nuclear features, but sometimes, because of the staining and because of the smearing, the nuclear features may not be very clear, and it has got abundant amount of eosinophilic cytoplasm, some of the cells like here. So this too would come in this particular list of differentials. And remember this word of caution, I'm trying to bring this up in every slide. That is the main purpose of this particular, one of the purposes of this webinar is to tell you that what are the various pitfalls. So I always try to highlight that you can have hepatocellular carcinomas with neuroendocrine differentiation. So once again, be very careful when trying to use one or two antibodies, because you might be making mistakes, because there are HCCs and they can show neuroendocrine differentiation in quite a few cases. The last one, I guess this is the last one in this list anyway. So hepatoblastoma can have a so-called, I'm sorry about this. Sorry about that. Okay, so it can show there is something which is called a fetal pattern. We are going to look at them in detail a little bit later. And the fetal pattern comprises of cells which have got this kind of a oval to polygonal look. They look like just hepatocytes, okay? So they come in the DDs when certain areas are sampled, and especially in a pediatric age group. But we are going to see more of hepatoblastomas in the next section. So this is that section, poorly differentiated HCCs and their lookalikes. So poorly differentiated HCCs and their lookalikes would be as follows. There are metastatic carcinomas, cholangiocarcinomas, hepatoblastomas, angiosarcomas, metastasis from melanomas, neuroendocrine tumors. I hate to put this in the list because they have a pretty distinctive appearance, but still, just for the sake of continuity, I'm putting this in this particular list. I'm not doing that previous, what I did a little bit earlier, that putting that collage of slides over here, because they're pretty difficult anyway. Right. Oh, actually I've done it. Right, I think I changed my mind. So anyway, so what you have over here are, once again, 6 different cases. And one of them is a poorly differentiated hepatocellular carcinoma. Right. Let us see if we've got these ones. So I'll wait for a few more seconds just for you to make up your mind. So one of them is a hepatocellular carcinoma. One is a melanoma. The melanoma is easy. One actually is a sarcoma. a metastatic adenocarcinoma. One is a cholangiocarcinoma, not a typical one. Another one is a hepatoblastoma, but these are. Right, so this one is HCC, which is poorly differentiated. This is a metastatic adenocarcinoma. This is a cholangiocarcinoma. The cholangiocarcinomas can sometimes show very big clusters and sheets and aggregates of cells. It is not always that they are small. We are going to talk about cholangiocarcinoma later. This can be very difficult, right? So these are the so-called embryonal cells of a hepatoblastoma. They're very closely packed cells. They're very closely packed cells. Melanomas, of course, can be very poorly differentiated, very tightly packed cells with low NC ratio, but if they have melanin, it's helpful. And this actually is an angiosarcoma, right, which can come in the DDs of carcinomas, poorly differentiated HCCs. So let's deal with them side by side. So in HCC, poorly differentiated versus metastatic carcinomas, there is like nothing like one size fits all kind of a strategy. You have to keep looking, try to pick up clues and put a story together. So one thing which is helpful is the presence of endothelial cell skirts, also known as marginal endothelial cells. If they are present, they are useful. So this is a poorly differentiated HCC. This is a metastatic adenocarcinoma, and as you can see over here, you can see with the arrows, see these are the endothelial cells, which are just wrapping around this huge trabecular of cells. Whereas over here, see they're fraying and there is no packing in by endothelial cells. So if this is present, it helps. Next, if you find a close admixture of malignant cells and clearly benign appearing hepatocytes, this favors, although I'm telling you there are exceptions, this favors the diagnosis of a metastatic adenocarcinoma. It favors the diagnosis of a metastasis, right? And this kind of difference in morphology, one has to remember, because if it is a very well differentiated HCC or a moderately differentiated HCC, it can be very, very difficult that whether you are sampling an HCC with the surrounding regenerative nodule. So if it is this kind of a difference in atypia, where it is clearly HCC, and these are clearly a tight cluster of neoplastic cells, it goes more in favor of metastatic adenocarcinoma. Here it is just a poorly differentiated HCC with kind of a, I just wanted to show that there are no two cell types over here. Almost all the cells over here are neoplastic. Now, this I have shown you before. That was in context of a moderately differentiated HCC, but they can also occur with poorly differentiated HCC. You look for these huge swans of bare nuclei, some of them showing prominent nucleoli, some of them showing intranuclear inclusions. When they are present, they are very helpful. Now, what about presence of glands? Now, this is one thing which doesn't help. Here is a HCC which shows an acini, right? But it's a HCC. And here, of course, is a Mets adenocarcinoma which shows an acinar pattern. So the presence of glands doesn't really help when you are trying to differentiate between these two conditions. Next, there are certain things when they are present that help with the metastatic adenocarcinoma. So one of the commonest adenoceas which metastasize to the liver are colonic adenoceas. And one of the features of colonic adenoceas is that they tend to show nuclei which have a kind of a columnar kind of a shape. They tend to stand in a line, and when you have this kind of pattern, this is more in favor of a metastatic carcinoma, possibly coming from the colon, okay, or it could come from somewhere else too. But when you see this kind of columnar type of nuclei amongst this malignant cell population, it favors a diagnosis of metastatic carcinoma. And of course, if you see this as compared to, that is the presence of mucin in the background, that's almost a slam dunk as far as non-hepatocellular carcinomas are concerned. Because remember that cholangiocarcinomas sometimes can be mucin secreting, although the presence of abundant amount of colloid-like mucin cholangiocarcinoma is extremely unusual, but hepatocellular carcinoma showing this amount of mucin is almost unheard of. So if you have abundant amount of mucin, this is one of our cases like last year, but this was a mucinous kind of adenocarcinoma from the, I think it was the one from the colon, which had metastasized to the liver. So if you have so much of mucin, it's very helpful. So this slide could almost take, I don't know how long, but I'm going to try to give this short. HCC, how to differentiate between HCC and adenocarcinoma? What is the role of immunohistochemistry? The first point, let's get them once at a time. If possible, you start with a panel comprising of HepTAR1, arginase, MOC31 and CK19. Right? So, if these two are present, then it is a HCC. If these two are present, so if they are positive for this, negative for this, it's HCC. If they are positive for these two and negative for this, it is a non-HCC, which means it could be a metastatic adenocarcinoma, or it could even be a cholangiocarcinoma. It doesn't just have to be metastasis. So basically what you are trying to differentiate is between a HCC and a non-HCC carcinoma, right? So cholangiocarcinomas always figure in that non-HCC side. Okay. Now, if after doing that you still have a question, the next panel could include glypican 3 and polyclonal CA. We'll show you a picture of polyclonal CA, which is going to be of help. Okay. If glypican 3 turns out to be positive, it definitely helps. Remember that arginase, if you compare between these two, arginase is a more sensitive and specific marker than FR, especially in less differentiated and the so-called scirrhous variety of HCC. I didn't talk about the specific HCC variant because they are mostly diagnosed, especially nowadays, on histopathology, so I didn't want to go into that. So arginase is a more sensitive and specific marker than HepTAR. Also remember that HepTAR may be positive in certain mets coming from lungs, stomach, pancreas, and esophagus. So you have to keep that at the back of your mind when you are using HepTAR. Glypican 3 is useful in less differentiated HCCs and is negative in benign hepatocytes. We've already talked about that. However, glypican 3, remember, may be positive in melanomas, and of course, they are positive in yolk sac tumors. Okay. HCCs versus metastasis from particular sites. Could there be like some antibodies which you can do and you can immediately say, well, this is mets, okay? So one is TTF1 and napsin for a lung primary. Rarely HCCs can even show TTF1 positive, but I'm sorry about that. HCCs usually show cytoplasmic TTF1 positivity, but that's not nuclear. Remember, CDX2 may be positive in 6% of HCCs, and they tend to be more positive in the poorly differentiated ones. So if you're just using CDX2 to differentiate between HCC and a metastatic colonic carcinoma from the colon, remember this point. CK7 and CK20, HCCs are CK7 negative, CK20 negative. That's what we know. But there could be cases of HCCs which are CK7 and CK20 positive. So if you're using CK20 to just call this one mets from the colon, well, there are cases of HCCs which are CK20 positive. So keep that in mind. They do not occur in all cases, but they occur in a small subset of cases. And if you are using a single or one or two antibodies, you are not using the whole panel, you are likely to make mistakes. PAC site positivity is very useful for a non-hepatocytic origin because I have not come across any report of PAC site positivity in hepatocytic tumor. Estrogen receptors may be positive in certain HCCs, and if you are thinking it is a breast carcinoma, GATA3 negative in HCCs. So this tend to be not too many work of GATA3 on HCCs. I've come across one article when they use GATA3 in a huge number of tumors. There are, I think, around 16 HCCs which are stained for GATA3. They didn't tell the grades of the tumors though, but they're all negative. So remember that a limited panel always carries the risk of falling into pitfalls. You should always begin with an exhaustive search for clinical history. And quite often, as somebody has said, your phone might be the best antibody. So pick up the phone and speak to the clinician, and you are going to get the diagnosis or the very important diagnostic clue. So talking of cholangiocarcinomas, they tend to show cells which are smaller, like smaller tubules. Somebody worked and said that they should have 10 proliferative ductules in the on smears. This was an article published almost 20 years ago. They can show necrosis. Again, you see that there are benign hepatocytes, and then there are these tiny clusters of cells. Some of them have a kind of a squamoid look. Some of them have vacuoles inside the cytoplasm. So this is another cholangiocarcinoma. Very tiny clusters of cells, small clusters of cells. And here, sometimes they can show very, very large clusters of cells. Okay, so this, I don't remember whether it's a cholangiocarcinoma or it's a metastatic adenocarcinoma. I really don't remember. It might be a mix-up, but the important thing which I want to convey is the fact that cholangiocarcinomas can sometimes show very large sheets and clusters of cells. So if you're just looking at the size of the sheets or clusters to differentiate between a cholangio and a metastatic adeno, you might be making mistakes. Sometimes they can show large clusters. Cell blocks can be very useful. This is a very interesting case. Here, as you can see here on the cell block, these are all hepatocytes, and there is a tiny cluster of, there are malignant cells over here. These are cells as they creep through the hepatocytic plates, as you see in histopathology. And if you don't believe me, this is CK7. You see all the hepatocytes are negative, and there is the cluster of malignant cells here. These are the cholangiocarcinoma cells, and here you did CK19, all the hepatocytes are negative, and look at, see, just these two tiny clusters of malignant cells which are lying over here. And I don't have the picture of the cell block over here, but they showed the typical morphology of cholangiocarcinoma. So what is the role of immunohistochemistry in cholangiocarcinoma? Use the same approach as previously described for differentiating HCCs from adenocarcinoma, right? Occasionally GPCs may be positive. So all the approach that you saw on the slide in differentiating of HCCs from metastatic adenocarcinoma, you can use the same one. Cholangiocarcinomas are positive for CK7, CK19, CK17, and CEAs with a diffuse cytoplasmic pattern. And this is one picture. So this is a cholangiocarcinoma using a polyclonal CA, the same one. It is showing a diffuse cytoplasmic pattern. It's going to show the same on monoclonal CA, right? Mm-hmm. But here, the polyclonal CA shows a canalicular pattern in the HCC. So this can be very useful in various circumstances. Now, this is very important. I said one of the stains which is positive in cholangiocarcinoma is CK19, but CK19 positive hepatocellular carcinoma has been now called a characteristic subtype. Not only is it a characteristic subtype, it's a subtype with a very poor prognosis. So if you're using CK19 to differentiate, please remember this. So cholangiocarcinomas versus metastatic adenocarcinomas in ISC is difficult to sort out with ISC alone. A close correlation with history and imaging is required because I can't really think of too many antibodies which will help us differentiate it unless, of course, it is coming, it's positive for TTF1 or napsin, strongly suggests the lung, Tax8, CDX2. All these things are going to indicate a particular primary, but CDX2, for example, has been seen in cholangiocarcinomas in a pretty good number of cases in big series and series studies, and also napsin and TTF1. Sorry about the spelling mistake here. It is napsin and TTF1 has also been reported in cholangiocarcinomas with very few cases. In a proper setting, this can be very, very useful. If you remember the cautionary notes. Hepatoblastomas, we are coming towards the latter part of the webinar. Not too much of time left, I guess. Hepatoblastomas, the most frequent liver tumors in children. Serum AFP levels are raised. The cytomorphology depends on the types and the subtypes. The types are epithelial and mesenchymal. The epithelial has various subtypes of cells: fetal, embryonal, small cell undifferentiated, and cholangioblastic. Whereas the mesenchymal type has an admixture of either fibrous, osteoid, or cartilage. The fetal type, and these are going to be clear as we see the picture, have moderate to high cellularity. Remember, the cells are oval to polygonal with low NC ratio, whereas the embryonal type, the cells have, again, a bit of a mistake here. It's a cell with a high nucleocytoplasmic ratio, so that's the correction. It is coarse chromatin, and the rosettes may be present. The mixed epithelial and mesenchymal type is going to have the fibrous tissue elements associated with, as well as cartilage and osteoid. On immunohistochemistry, very interesting, it is Hepar positive, canalicular positivity on CA, Glypican is positive, glutamine synthetase is positive. The embryonal pattern show positivity for alpha-fetoprotein and Glypican-3. So that's why it is going to be very difficult if you're trying to differentiate from a hepatocellular carcinoma. So this is a hepatoblastoma which shows a predominance of the embryonal pattern with very tight clusters of cells, whereas here is a hepatoblastoma with a predominant of a fetal pattern, which would make it in the group of differentials with the so-called moderately differentiated HCCs. As you can see that the cells are got a moderate amount of cytoplasm. Some of them have got scanty amount of cytoplasm. Sometimes it's just a mix. It is difficult to just separate into various groups. Right. So hepatoblastomas, remember, are the second most common malignant tumors in childhood after hepatocellular carcinomas. The second most common malignant tumor in children after hepatoblastomas. The fetal pattern may be very difficult to differentiate for a moderately to poorly differentiated HCC. So you have to keep that at the back of your mind. So neuroendocrine tumor, I am not going to spend too much of time. The look is extremely distinctive with most of the cases. Not going to describe it to any degree. The plasmacytoid cell, the salt and pepper chromatin, these granules in the cytoplasm. And I'm going to just rush through this. Next, we are going to go to the tumors with the primitive look. We are going to go very quickly through this group. In this, we have firstly the small round blue cell tumors, embryonal sarcomas, hepatoblastoma, the embryonal areas, which we are going to see a little bit later, and mets from small cell carcinomas. Right. This is a Ewing sarcoma. You can have very rarely you can have a primary Ewing sarcoma of the liver, or it can metastasize to the liver. Embryonal sarcomas, the next one, the third most common malignant liver tumor in children. First, hepatoblastoma. Second, third, embryonal sarcomas. They usually show moderate to high cellularity with a pretty heterogeneous population of cells, and they can even have very pleomorphic cells. Hyaline globules, if present, are pretty distinctive because they are PS positive diastase resistant. They can show a dot-like positivity on cytokeratin. They're positive for alpha-1 antitrypsin and anti-chymotrypsin. This is interesting. Alpha-fetoprotein is negative. HCCs can be alpha-fetoprotein positive. Hepatoblastomas are alpha-fetoprotein positive. But this is one of these childhood tumors. They're alpha-fetoprotein negative. So this is useful. Despin is variable. Glypican may or may not be positive. This is these are a couple of pictures I've got from my good friend, my guru, Professor Pranab Dey. So he was kind enough to share them with me. Embryonal sarcomas, extremely pleomorphic cells, some very poorly differentiated cells. This one is a clear picture from the Eurocytology website, but again you have got these very undifferentiated cells, some very pleomorphic cells, and of course, very characteristically these kind of chondromyxoid and mesenchymal fragments which are often there. Next is a mets from a small cell carcinoma of the lung and give you a very undifferentiated picture. This is a positivity if you don't believe it's from the lung. It's a synaptophysin as well as TTF1 because you know lung small cell CAs are TTF1 positive, so we are able to pin the diagnosis of mets from the lung. Among spindle cell lesions, these are the list of spindle cell lesions, and I think I'm going to just go through them. Hemangiomas, mesenchymal hematomas, mesenchymal areas of hepatoblastoma, GISTs, yes of course. Carcinoid tumors can have spindle cells, we have seen a few. Primary and metastatic sarcomas of the liver and sarcomatoid carcinomas. So we are not going to spend too much of time on these. Maybe some other time we can do another webinar on rare hepatic tumors if possible. So just to let you know that look at this tumor. It just looks like a spindle cell tumor, but it was positive for chromogranin and synaptophysin. This was a carcinoid, a spindle cell type. Anywhere in the body, when you see a spindle cell tumor, this kind of morphology, in a suitable location, don't rule out carcinoid tumors. They are always there. This is hemangioma, which was aspirated, and you have these hemorrhagic background. They're usually very paucicellular if you get to see them, and they're most often not aspirated, and you have these spindle cells. A mesenchymal hematoma, from Das et al., published in the Journal of Indian Association of Pediatric Surgeons. They usually show a low to moderate cellularity found in children with epithelial and mesenchymal element combining both myxoid and myxofibrostoma. So this again can give rise to spindle cell tumor. And of course, never to forget GIST. This was a GIST in the liver, and this is, I don't have the CD117, it was positive, I couldn't get the, I forgot to take the picture. So this is, I just found the dog one. So this is a gastrointestinal stromal tumor which can occur most of our Mets, but you can also have primary GISTs in the liver. So livers are sites of extra gastrointestinal GISTs. Angiosarcoma, another paper from PGI showing this kind of cells, some spindly cells. Okay, so as far as sarcomas are concerned, angiosarcoma should come in the DD. Another sarcoma which very commonly metastasizes to the liver is a leiomyosarcoma. I do not have pictures for that. And also there is a spindle cell tumor associated with Epstein-Barr virus. That is smooth muscle tumor associated with Epstein-Barr virus can also be found in the liver, and in suitable circumstances you should also do EBV stains. The last one is lymphoid and histiocytic cell region. I've just made a list just in case you want to come back and take a look, and I've just got one slide. This is a diffuse large B-cell lymphoma, non-Hodgkin's lymphoma, large B-cell lymphoma affecting the liver. This one is a Hodgkin's, a representative slide of the liver, and this, with all these kind of cleaved nuclei, this is a Langerhans cell histiocytosis. So I guess this is the last slide. I would like to thank you all for your time. I would like to thank the staff of our laboratory, especially the technical staff who take a lot of time trying to get these slides out and put them together for me so that I can take pictures. Many of them I have used from the net, but most of the material I've shown you is from our material, and I would like to thank them, and thanks to all my colleagues in the department. Thank you very much. Thanks for your time. Thank you, Nadeem. I can take questions now.
Thank you. Wonderful, as usual, typical MRINMAY material. Hand holding, you teach so well, my God. So wonderfully, you've gone one by one, slowly and very nicely explaining every bit of it, especially talking about the pitfalls, the confusions, and they are the real confusions which everybody faces, who are reporting aspirates from liver. They're very, very common, and you've done it so wonderfully. Excellent presentation, Mrinmay. Wonderfully done.
Thank you, Nadeem. Thank you very much. As I said in the beginning, I just wanted to, because I know that possibly most of the people who watch this they watch it later, and I wanted to create kind of a place where they could always come back and refer to, like, and in difficult situations and circumstances.
Absolutely, you got it absolutely right. That's it. That is exactly the purpose, the whole idea of having all this here, so that you can come back, go back, have a look, come back again and have a look again.
Yeah.
And that's so important. Yeah. And I can't see any questions on the YouTube, and neither there are any questions on the Google Meet right here. But one thing which you rightly said, it is more important to use the telephone, which is the best antibody.
Yes. So quite more often than not, that sorts out the problems.
Yeah, true. It does. It does in most of the situations. Absolutely right. Yeah.
Yes.
Great. Yeah, wonderful.
Yes.
It is so nice to hear that by the end of this year you will be in India and most probably in Calcutta. So we will definitely have a very wonderful cytopathologist in our country to help us out.
Thank you, Nadeem.
Listening.
I look forward to it.
Yes, we will welcome you, and we would like you to be here to contribute in actual terms in reporting. So nice of you. So we'll be hearing you again on pancreatic lesions. Is that right?
Yes, pancreatic lesions, because that is I'm looking forward to it, because it's just a close neighbor, the pancreas, and there's such a huge difference between the approach or the way FNA has come up on pancreas as compared to the liver. Because here we see, I think pancreas now in our department has become one of the commonest things which you aspirate, pancreas and mediastinum.
Okay,
So pancreatic FNAs are becoming more and more popular, and so I'm really looking forward to talking about pancreas. And let us see, I'm looking forward to it. Thank you very much, Nadeem.
Thank you, Mrinmay. Take care. God bless you. Take care. Bye-bye. Thank you so much.
Bye, bye, bye.
Bye-bye. Bye. Please share the PDF, it will be very important.
I shall share the PDF. There are a few mistakes. I shall correct them before I share them.
Yes,
I'll do it
take your
tonight.
time, no issues. Right.
Yeah,
Take your
sure.
time.
I'll do
Thank
that.
you so much. Bye-bye. Good night. Bye.
Good night. Bye.